Good afternoon. Today we'll be having a class on periodontal pathogenesis.
Coming on to the learning outcomes, we analyze the microbial interaction with the host in the periodontal status, relate and analyze the various factors that play a role in bacterial evasion of host defense mechanisms, point out the microbial mechanisms of the bacteria for the host tissue damage, and explain the mechanism of host tissue destruction.
So, the contents of this class would include an introduction, the model of periodontal pathogenesis, histopathology of the periodontal diseases, inflammatory response in periodontal disease, where I would be describing about the microbial virulence factors as well as the host mediated inflammatory factors, immune response in periodontal disease, how are we going to link pathogenesis to the clinical signs of diseases, the concept of host susceptibility in periodontal treatment planning, and we'll finish it with conclusion. So to start with, pathogenesis as per Karanza has been defined as the origin and development of the disease. It is a step-by-step process that leads to the development of the disease, resulting in a series of changes in structure and function. It is a process by which the etiologic factor can cause the disease. So in case of periodontitis, so the main etiologic factor for the periodontal disease is your dental plaque. Formation of dental plaque occurs through three main stages. First is the formation of an acquired pellicle. So you can see the tooth surface here. So the tooth surface after the first stage formation of an acquired pellicle. The second stage is that there is an initial adhesion and there is an attachment of bacteria which is present. After this, the third stage follows the colonization and the plaque maturation. Finally, there is a dispersion. So this is how the dental plaque is formed, and this results in changes in the gingival and the periodontal structures, resulting in the periodontal disease. The dental plaque, when it gets mineralized, that is called as calculus. Otherwise, the contributing factor for the periodontal disease is calculus, which is a mineralized plaque layer covered by a layer of an unmineralized plaque. After 2 to 12 days, if the plaque is left unclean, it changes into the calculus. So these are the main agents which are going to cause diseases, which are the causative factor for the periodontal disease. So now coming for the model for pathogenesis of periodontitis. So several authors they had come with the conclusion telling that microbial challenge is the main status for the main reason for the clinical signs of diseases of initiation as well as progression, which means that it is just because of the microbes that there is signs of disease present in the oral cavity. Periodontitis is occurring. But further, the authors came to a conclusion that for each of the microbial challenge, there is going to be some host response which is going to be occurring. So this is both going to be an immune mediated as well as an inflammatory mediated response. So because of this that is then host immunoinflammatory response, so this results in clinical signs of the disease. So this was the next set of theory which school of thought which came into existence. But at last there was a person called as Kahneman, where he came up with a model for what is actually occurring in periodontitis and why the condition is occurring. So to put it in short form, we will be explaining about this again in the later slides. So I will just tell in short form what generally pathogenesis of periodontitis is. So here, whenever we face dental plaque is left out without cleaning in the oral cavity, the microbial challenge is left open. So which means that from the dental plaque, the antigens and the lipopolysaccharides and the other virulence factors from the microbes are released into the oral cavity, that is into the host. So host, that is we, tend to give an immune as well as an inflammatory response. So in this response, we tend to give out antibodies and neutrophils. So because of this release of antibodies, we don't only release antibodies and neutrophils. Along with this, we tend to release certain immune mediators also, such as cytokines, prostanoids, and matrix metalloproteinases. So these three, they don't only destroy the microbes but also tend to destroy our own connective tissue also. So it is like an autoimmune response which is occurring. So because of that, there is connective tissue as well as bone metabolism is getting disrupted. In other words, it is getting a problem is there. The problem starts, and therefore there is clinical signs of diseases again. So this is not the only mechanism which is taking place. It has also been reinforced that there could be certain genetic risk factors which play a role in the response which the host gives, or how the tissue changes takes place in the body. Apart from that, there are some environmental and acquired risk factors also, such as your smoking, diabetes. So all this tend to influence the host response as well as the connective tissue changes. So at last, because of all these factors, you see the clinical signs of diseases which are present. So to put it in short form, it is not only the bacteria which causes the disease, but it is also the host who is not able to compete with the amount of inflammatory factors which is being produced, results in clinical signs of the disease. So this is what we will be seeing in this particular class. So next, coming on to the histopathology of the periodontal disease. So before going into the disease part, I will brush once into the clinical healthy gingival tissues. So you guys know that clinical oral healthy gingival tissues consist of an oral epithelium and a sulcular epithelium and the junction epithelium. So this junction epithelium is very important because this forms an important attachment to the tooth, and this acts as a barrier for any of the plaque entering inside, plaque microorganism entering inside. Of course, it is little semi-permeable. There is a rapid turnover of this junction epithelium, and antimicrobial defense is good, GCF flow is good here, and therefore junction epithelium kind of resists the entry of the microorganisms into the connective tissue. But even in a gingiva that appears clinically normal, there is some low grade of challenge being presented by the subgingival plaque bacteria. So essential mechanisms should be developed by the host to combat the bacterial challenge, to prevent the bacteria and their products from infiltrating the tissues. But if this becomes an excessive dysregulated immune inflammatory response, that is, if our body tends to respond more than normal for a given bacterial challenge, then it results in an increased tissue breakdown. So overt signs, clinical signs of gingivitis do not develop because innate and structural defense mechanisms, including the following. So to tell about these lines, though most of us do have some amount of dental plaque or calculus, we don't really develop any clinical signs of gingivitis. This is because of these following factors. Any clinical signs of gingivitis don't occur for people even having very good amount of plaque, due to the fact that there is a maintenance of an intact epithelial barrier, outflow of GCF from the sulcus, sloughing of the surface epithelial cells of the junctional and sulcular epithelium, presence of neutrophils and macrophages in the sulcus phagocytizing the bacteria, and the antibodies in the GCF. So in other words, to tell that though plaque is present, subgingival plaque activity is going on in almost all the individuals, but the clinical signs of gingivitis are not shown in most of them. It is because of these following factors which helps us to stay out of the disease. But if the plaque accumulation increases so that the defense mechanisms of our body are overwhelmed and not able to manage it, then inflammation and the clinical signs of gingivitis will develop. Alright. Coming on to, so after telling that there's going to be clinical signs of gingivitis which are occurring, so we'll see what are the stages of gingivitis. So this was given by Page and Schroeder. So they classified the stages of gingivitis into 4 types. We have already seen this in your classification lecture. So we will go on with what happens in each of the stages. So the first stage is your initial lesion. This corresponds with the clinically healthy gingival tissue, which occurs to 2 to 4 days immediately after your plaque accumulation. After plaque accumulation, 2 to 4 days, you have this initial lesion which is occurring, where there is a little vascular dilatation and vasculitis. This area is filled with neutrophils. Neutrophils is always the first line of defense, and there starts the perivascular loss, that is collagen loss starts to take place. There is an increase in the gingival fluid flow. So after this stage, if the plaque is not removed, 4 to 7 days later you have the early lesion. This corresponds with the early gingivitis which is clinically evident. So here there is a vascular proliferation with red apex atrophic areas. The immune cells predominant here are the lymphocytes. There is increased loss around the infiltrate, and here erythema and bleeding on probing is present. So when the patient comes first, the very first thing which we check in the patient is bleeding on probing, and it is found that if the patient is in this stage of the gingivitis, it will be evident for us. Next stage is your established lesion. This corresponds with an established chronic gingivitis which occurs 14 to 21 days after the plaque accumulation. So this combines both the features of stage 2 as well as blood stasis. So since there is going to be increased amount of vascular proliferation, one point of time the blood vessels are so much more that they hit with each other and result in stoppage of blood a little bit, resulting in blood stasis. The changes are more advanced in case of junctional and sulcular epithelium. The predominant cells here are the plasma cells. There is continued loss of collagen. Changes in color and texture do occur in the established lesion. So coming on to the next stage, there is the advanced lesion. This marks the transition of the disease from the gingivitis to periodontitis, which means that from an reversible state it is going into an irreversible state. So at least at this point we will have to meet the patients have to come to us to take proper care. So here it is found that there is a predominance of neutrophils in the pocket epithelium and the pocket. Dense inflammatory cell infiltrate in the connective tissue is present, especially plasma cell. So there is an apical migration of the junctional epithelium to preserve an intact junctional barrier. So this occurs to us as pockets, that is the junction epithelium migrates downwards. There is continued collagen loss that results in larger areas of collagen depleted connective tissue. Not only this, the most important that there is osteoclastic resorption of the alveolar bone, which means that bone gets resorbed, resulting in periodontitis. Bone loss occurs in periodontitis. Next, coming on to the inflammatory responses in the periodontium. So inflammatory response generally has two major mediators which are being produced. So this inflammatory response by the body results in production of two mediators. One is given by the subgingival microbiota, which are the microbial virulence factors. Another is by the host immune inflammatory response, which are the host derived inflammatory mediators. So microbial virulence factors includes your lipopolysaccharide, bacterial enzymes and noxious products, microbial invasion, fimbria of Porphyromanus gingivalis, bacterial DNA and extended bacterial DNA. Whereas host derived inflammatory mediators include cytokines, prostaglandins and matrix metalloproteinases. So to tell in other words, so once the microbes enter into the body, they challenge the host with the help of production of all these microbial virulence factors. So in response to this, the host tends to produce cytokines, prostaglandins and matrix metalloproteinases. Now coming on to the first one, first microbial virulence factor, that is lipopolysaccharide. So this is generally found in the outer surface of the gram-negative bacteria. It acts endotoxin, elicits a strong immune response. Immune system recognizes this lipopolysaccharides. So the lipopolysaccharides are recognized by the immune system through toll-like receptors called TLRs, which is present on the cell surfaces. So this is present both on the neutrophils or it is present on the macrophages. So these cell surfaces that recognize the microbe associated molecular patterns, which are conserved molecular structures located in diverse patterns. So this TLR9 is able to recognize the lipopolysaccharide. So if it is like and later it results in deregulated inflammation. If the body combats the effect, then the normal tissue homeostasis is restored. If the body cannot combat the effect, then it results in chronic inflammation and inflammatory bone loss. In other words, lipopolysaccharide is being recognized by the toll-like receptors present on the cell surfaces. Just understand this. The second virulence factor is the bacterial enzymes and the noxious products. For the three noxious products are the short chain fatty acids, proteases, and gingipains, which are produced by the Porphyromonas gingivalis. Short fatty acids aid the bacteria Porphyromonas gingivalis infection through the periodontal disease tissue destruction, and also provides nutrient to this particular bacteria to develop. Proteases breaks down the structural components such as collagen and elastin. Gingipains of the Porphyromonas gingivalis results in increased tissue damage and increased cytokine production. So the third microbial virulence factor is the microbial invasion. Periodontal pathogens such as Porphyromonas gingivalis and acetocomitans, acomitans tries to invade the gingival tissues through the connective tissue. The fourth one is the Fimbria of P. gingivalis, also stimulates the cytokine production. Now, next coming on to the host derived inflammatory mediators. So, what we taught till now was the what microbes tend to give out, but the host in response to the microbe action tends to give out certain mediators. Those includes the cytokines. So, these play a fundamental role in the inflammation and are the key inflammatory mediators in periodontal disease. They are soluble proteins secreted by cells which act as messenger molecules that transmit signals to the other cells produced by such a lot of cells. So, one of the main cytokine in this interleukin, in this cytokine family, is the interleukin 1 beta. So, this stimulates the prostaglandins, the nitrous oxide, so resulting in vascular changes associated with inflammation. It also stimulates the secretion of chemokines. So, we will be seeing about all this in later slide. It synergises with the pro-inflammatory cytokines and PGE2 to induce bone resorption. So, to put it in main words, one of the main cytokines resulting in disease is the interleukin 1 beta, associated with vascular changes, changes on the endothelial cells, as well as changes with the bone. Next, coming on to prostaglandins, this is a lipid compound derived from the arachidonic acid. So, PGE2 is a key inflammatory mediator, stimulating production of other inflammatory mediators and cytokine production. PGE2 also stimulates bone resorption and plays a key role in periodontitis progression. Third host-mediated inflammatory response mediator is a matrix metalloproteinases. So, this is a group of enzymes that break down the structural proteins of the body, matrix metalloproteinases, into collagenases, which further break down the collagen. Key MMPs in periodontitis includes matrix metalloprotein 8 and 9, which are produced by the neutrophils as they migrate through the periodontal tissues, thus contributing to periodontal tissue breakdown. So, if you don't understand, I have again put forward in a form of a flowchart wherein inflamed periodontal tissues has large number of infiltrating cells like neutrophils. So, neutrophils in response to the microbes tend to produce certain products such as matrix metalloproteinases. So, the main ones which are predominant in periodontitis have been found to be MMP8 and MMP9. So, these proteinases not only destroys the microbes, but otherwise it also results in the development of collagen depleted areas within the connective tissue. In other words, there is a degraded type 1 collagen in PDL, resulting in periodontal tissue destruction. So, to put it in short, so there are going to be 5 microbial virulence factors and 3 host immune inflammatory mediators. So, how do we link the pathogenesis to clinical signs of the disease? So, what generally occurs in the histopathology and how is it seen outside on the gingival tissues? So, if the inflammation becomes more extensive because of the increase in the bacterial challenge, then we can see an increase in vascular permeability, vasodilatation, leading to erythema and edema. So, here you can see a condition where there is edema which is present and erythema which is present. So, because of this, there is a little gingival swelling, slight deepening of the sulcus is present. After gingival swelling, slight deepening is present. So, since it is deepened, there is a sulcus is little deepened. If there is going to be any plaque here, it compromises the plaque removal. So, in response to this, there is an increase in inflammatory cells which leads to the development of collagen depleted areas below the epithelium, and the epithelium proliferates to maintain its downwards to maintain its integrity. So if the bacterial challenge still persists, which means that if you have not still gone in for scaling or oral hygiene maintenance, then the cellular and the fluid infiltrator continues to develop, and the inflammatory cells soon occupy a significant volume of inflamed gingival tissue. So the main cell is your neutrophils. So neutrophils not only phagocytize and kill bacteria, but on the other hand release a large number of matrix metalloproteinases. So it itself, the neutrophil, which should act as a good being, turns back to us, thereby producing large number of matrix metalloproteinases, leading to breakdown of the structural components of periodontium. Not only this, it releases potent lysosomal enzymes, cytokines, ROS, causing further tissue damage. The opportunity for the repair starts getting limited, and the epithelium continues to proliferate apically, deepening the pocket further. Now coming on to rankle, it is a cytokine like molecule that binds. So here you can see that it binds to the rank. So in this way it tends to bind, causing maturation into fully differentiated osteoclast. So when these two bind together, then a normal osteoclast or a normal bone cell changes into an osteoclast cell, and then destruction takes place. Osteopontegrin, that is OPG, is a cytokine like molecule that binds to the rankle and inhibits the interaction between the rank and rankle. That is, this rank which is present starts to bind, the rankle which is present starts to bind to the OPG. But in case of disease, so this is in the normal case wherein the OPG binds with the rankle, and very rarely the rankle and the rank bind together. So when the rank and the rankle bind together, what happens is that the bone, normal bone cell changes into an osteoclast cell, resulting in destruction. Whereas in case of a diseased activity, there is more amount of rankle cells. So this rankle cells tend to bind with more amount of rank cells, resulting in more bone resorption which is present. If you guys are not able to understand this particular slide, please do come in person. I will explain it once more. So coming on to immune response in periodontal pathogenesis. Immunity is defined as the resistance of the host to pathogens and their toxic products. Innate factors such as complement, resident leukocytes and mast cells play an important role in signaling endothelium, thus initiating the inflammation. Acute inflammatory cells, that is neutrophils, protect their local tissues by controlling the periodontal microbiota within the gingival crevice and the junctional epithelium. Chronic inflammatory cells protects the entire host from within the subjacent connective tissue, the bacteria. So next, coming on to the schematic changes which takes place during the development of gingivitis and periodontitis. So generally, when there is going to be a pristine gingiva, that is when the gingiva is in a very good state, there is a little neutrophil migration into the coronal part of the junctional epithelium and crevice to stop the flow of bacteria coming inside the connective tissue. But when there is going to be a little more plaque, so this green represents your plaque, so there is more amount of neutrophil which is present. So there is an infiltrated connective tissue, that is neutrophils comes to this area and it allows it to be moved to the junctional epithelium. So this is a normal healthy gingiva. But when there is going to be still more increased plaque present, then there is an increased neutrophil immigration and proliferation of the junctional epithelium, which means that neutrophils are much more, and then again it is presented to the junctional epithelium a little more than your previous status. So this tries to engulf the bacteria in the engulf the bacteria as well as kill its products. So during this process, the junctional epithelium also proliferates a bit. So when it is going to be in established state, you can see the amount of neutrophil which is infiltrated in the connective tissue and the neutrophils which have gone into the junctional epithelium in response to the bacteria. So this all happens which helps in combating the infection. So till this status, it is a reversible status. But once the body is not able to manage it, there is so much of infiltration, there is apical migration of the junction epithelium, which means that, so you can see that junction epithelium has come down a bit, which means that pocket has formed, and this results in more amount of bone loss, so resulting in periodontitis. At this stage, it is irreversible. So next, coming on to the immune responses. So I wanted to tell here about the innate immunity. So innate immunity, it is a resistance to the infection which an individual possesses by virtue of its genetic and constitutional makeup. So just brush up your knowledge to the microbiology of your second year, so you will know what is innate immunity. So innate immunity is like inborn. So it is a resistance which an individual has for an infection by virtue of its genetic constitutional makeup. It occurs prior to contact with any of the microorganisms or their products, is not essential for this case. Unlike the adaptive immunity, it refers to the elements of the immune response that are determined by the inherited factors. So it has limited specificity, it's fixed, they do not change or improve during an immune response. They are activated when the primary defenses are breached. If innate immune response fails to eliminate an infection, then the effector cells' adaptive immunity are activated. So what are the adaptive immunity? So we will see it in the next few slides. So for innate immunity, there are certain features which we have in our oral cavity. The first and foremost for innate immunity is the saliva. So saliva has such a lot of constituents such as antibodies, immunoglobulin A, histatins, cystatins, lactoferrin, lysozymes, mucins, and peroxidase, which contribute to the innate immunity. So mostly the major one is your immunoglobulin A, which is targeted against the periodontal pathogens. Others contributing to the innate immunity includes your epithelial cells and the gingival clavicular fluid. So if the innate immunity is not been done there in a body, then it goes to the second immunity, that is the adaptive immunity. So which means that it is a little slower and resilient on the complex organisms between the antigen presenting cells, on complex interaction between the antigen presenting cells, the T and the B lymphocytes. So here the antigen specificity of the response that facilitates specific targeting of a diverse range of effector elements and the ability to improve the exposure to the antigen. So T cells are predominant in the gingivitis and stable periodontal lesions, whereas once the body is not able to cope up, then it goes in case of active periodontitis, it goes to B cells, which are predominated there and are associated with pocket formation and progression of the disease. Certain other characteristics, and they tend to form the as an antigen presenting cell. So what it generally does, so when a bacteria is present, the bacteria sends certain factors which attracts the neutrophils towards the bacteria. So this is called as chemotaxis, that is the movement of the neutrophils in towards the bacteria because of its attractive factor is called as chemotaxis. So after it has come near it, it tends to engulf the bacteria. So this process is called as a phagocytosis. So once it is engulfed, it starts to kill inside by means of defensins, lysozymes. Killing activity takes place with the help of other oxides too. So once this takes place, the bacterial component, the cell becomes an antigen, which means that the bacteria, if it comes again to our body, the body recognizes it before itself by means of this antigen processing and presentation. So what it does, so this bacteria which enters inside goes into certain processing mechanisms and has produced certain receptors on the surface, which helps us to recognize that this bacteria has already come to the body. So in response to this, cytokines are being presented. So neutrophils act as an antigen presenting cell. So the model of pathogenesis, periodontal pathogenesis, has been already explained before. But there are certain individuals, though they have so much amount of inflammatory factors like plaque or calculus, they don't get disease itself. Whereas on the other hand, there are few individuals that even if they have little amount of plaque, they have hell lot of infection. Why is that so? So immune response to the bacterial challenge never occurs in isolation but takes place in the context of the other host and environmental factors that influence these responses and thereby determine the progression of the disease. So here is the a curve where inflammatory response characteristics in relation to the bacterial challenge. A given bacterial challenge results in differing level of inflammatory response according to the response profile of an individual. Most of the people are close to this normal and produce a certain level of inflammatory mediators for the given challenge. But those who are very hyper responders generate an excessive inflammatory response to the same bacterial challenge and cross the threshold into an active disease at an earlier stage itself. So those who are hyper-responsive produce lower level of inflammatory mediators and despite a significant bacterial challenge may never develop periodontitis. So this is what the authors found, that you could have either hyper-responsive individuals, normal responsive individuals or hyper-responsive individuals. So based on all this, the concept of host susceptibility to treatment planning came into plan. So in the disease status, it has been found, so this is a balance. So if this balance is disrupted, then you end up in the disease. So in the case of health, you generally you have reduction of the risk factors. You have more amount of anti-inflammatory or protective mediators such as interleukin 4, interleukin 10, etc. With host modulation therapy, resolution of inflammation, and therapy from the professionals if it is there, then you have a healthy status. But on the other hand, if it is going to be more amount of risk factors like genetics, smoking, diabetes, overproduction or pro-inflammatory mediators are more, underactivity of the host response, poor compliance or plaque control, subgingival microbial burden is low, then you have a disease status. So just go through the linings which I have given underneath. So this tells about this balance between the disease and health. So if there is going to be more components on the disease side, then the graph is going to shift to the diseased aspect. If it is going to be more components on the health side, on this you do have the treatment concept of with the help of treatment planning. So as I told you, this is a model given by Kahneman, which tells that not only microbial challenge, the host response is also required. So antimicrobials produce bacterial products can be combated by the antimicrobials. The host cells produce prostaglandins, cytokines and MMPs. So that also can be brought down by the NSAIDs and the periostats. So this all reduces the bone resorption and the connective tissue activity, thereby reducing the clinical signs of the disease. So in other words, reduction of the bacterial burden can occur with the help of scaling and root planing and topical antimicrobials. Risk factor reduction has to take place with help of smoking cessation therapy and diabetes control. Host response can be done with the help of certain drugs which helps in inhibition of the matrix metalloproteinases. So all these three together only will be helping us in clinical improvement.